Welcome to the Limi Children's Hospital, where children come first. We like to call it LCH. It's a specialist pediatric center, caring for all kids up till the age of 16. We are located right here in Wuse 2, Abuja. We have a remarkable sensitivity to children's needs, that is what stands us out. We are specialized in neonatology, with our state-of-the-art neonatal intensive care unit. We are also a general pediatric hospital.
Yeah, all right. Once again, good afternoon, dear listeners. Like I earlier said, we are having a hybrid session today with a physical audience right here and a virtual audience. We respect you all. Today's presentation is special. We would have at some point a presentation by GE company, medical representation, medical representative, but as we go along, we would get to know more about that. This is Limi Hospital. We've been in existence since the last 40 years. And as you can see on our screen, the Limi Hospital by your far right, and then the cardiovascular specialty hospital. And then we are talking from the Limi Children's Hospital. We are pediatricians making this presentation today. Our hospitals, this webinar is part of giving back to the society in terms of continuous medical education sponsored by the Limi hospitals. The hospitals carry an S, it's plural, Cardio Care Multispecialty Hospital, located in Garki. We have our cardiovascular medicine specialty hospital with services for cardiac interventions, cardiac catheterization, the busiest cath lab in the country as it stands currently, services for dialysis, cardiology, nephrology, endocrinology, neurology, all that. And the multi-specialty hospital, the headquarters, located in Central Business District, Abuja, services for family physicians, family medicine, obstetrics and gynecology with IVF services. We also see children there, general surgery and all that. Now, today, the Limi Children's Hospital will be making this presentation. We're happy to have you join us as we make progress. Who are we, Limi Children's Hospital? With me is a colleague who will tell us a little about the Limi Children's Hospital.
Thank you very much, Dr. Peter. I'm Dr. Samuel Mogaji, and I'm a medical officer in the Limi Children's Hospital in Wuse 2. So we have, as part of the services, we offer pediatric cardiology, nephrology, pediatric endocrinology, very thriving neonatal intensive care units, where we also have a transport incubator. And then we have pediatric neurology and a developmental clinic. Also, it's worthy of mention our speech therapy clinic, that runs hand in hand with the developmental clinic.
Oh yeah, so those are nurses. Nurses celebrated Nurses Week not long ago.
Yeah.
So those are some of our nurses there. Right, so this is our pediatric cardiologist performing echocardiography on a preterm unit inside the transport incubator.
Yeah.
So we have services of a mobile transport incubator with echo services, very, very possible. Yeah. Right. So you
all right. Welcome everyone. This is the May webinar from the Limi Children's Hospital, and today we'll be talking about the neonatal respiratory supports in terms of basics of mechanical ventilation. So, sir, when we talk about mechanical ventilation in neonates, what exactly do we mean?
All right, so that's like fast forwarding. We would go ahead. Yeah, so mechanical ventilation, a ventilator, mechanical ventilation, is a device that provides. So when you have children with increased work of breathing, and the result is resulting from a respiratory pathology, cardiovascular pathology, neurologic impairment, you need to assist their ventilation. So that device that is automated and provides all or part of the work of breathing in these children is a mechanical ventilator.
Wonderful, wonderful.
Yeah.
Just for our for our participants, during the course of the presentation, if you have any questions, you can drop that in the Q&A box or in the chat box. All right. Also, you can raise your hand so that we know that you have a question, but most importantly, please record that in the Q&A or chat box. Thank you.
Okay, so we've defined the mechanical ventilator. As far as we're concerned, for the layman, it's a machine that helps breathing. Yeah, so why do we need to ventilate?
Right, so there are various reasons why we might need to ventilate a neonate, most especially. Part of which is when we observe respiratory distress or respiratory failure. And respiratory distress is not just something that one will subjectively look and say, it's like this child might be in distress or not. Down the line, we'll see objective measurements that we can use to classify respiratory distress.
Yeah, so actually respiratory distress, like an introductory, just an overview. So we have a unit in front of us and you look at certain parameters, the respiratory rate. Yeah, so if it's too fast, tachypnea. If it's too slow, bradypnea, you're looking at respiratory distress.
Okay.
If the baby is using effort to breathe, respiratory distress. Are we having a desaturation of respiratory origin, respiratory distress? And if there's cyanosis, so but we'll look at this in the tabular form. Usually for beginners, you have some challenges differentiating between respiratory failure and respiratory distress.
Yeah.
But this presentation will clear that down.
It's really difficult sometimes to make that delineation, but we'll see, we'll learn that as we go on. Also, when we talk about mechanical ventilation or anything pertaining to the respiratory system, we need to have some firm knowledge about neonatal arterial blood gases, and that is where we can make such diagnosis of respiratory acidosis when we see a pH of less than 7.2 or increased partial pressure of carbon dioxide. Also, when we have hypoxia, as indicated there, we can see it as a reason to ventilate a neonate. In situations where we have severe apnea or bradycardia, these are also reasons why we need to ventilate a neonate. And last but not least, to treat intracranial hypertension, that is treated by hyperventilating, and we can't tell that neonate hyperventilate, We can do that with the use of the mechanical ventilator.
Yeah, so why we still have slides ahead that will talk a lot about acid-base imbalance. This, when there is a problem with oxygenation, so low oxygenation, the partial pressure of oxygen is low.
Yeah.
When there's a problem with ventilation, we ventilate to get out carbon dioxide. Yeah. So there's a problem with ventilation, and so the carbon dioxide accumulates, so the partial pressure increases. And because it's acidic, you have the pH dropping. That's why we have respiratory acidosis, we have hypoxia there, and the other indications. We have a comment in the chat. Okay, fine. So please remember to put your questions in the Q&A section. So now, respiratory assessment in newborn. So we want to look at, so we have a newborn before us in the neonatal intensive care unit, and we want to tell, is this child having, is the respiratory status normal? Are we having respiratory distress? or is maybe getting to respiratory failure. This already tells us that there is a spectrum. It tells us there's a spectrum: normal respiratory status, respiratory distress, then respiratory failure. So we have this modified down scoring system, which, like what I said earlier, we're looking at respiratory rate, looking at presence of bluish discoloration of the mucous membranes, so cyanosis, looking at effort in breathing, which is shown by retraction, grunting, and then auscultating to tell us the level of air entry. So can you please explain this?
Right. So when we have scores that are good, that is 0. When we have really bad scores, that is in the column of 2. So when we have in these neonates severe tachypnea in terms of respiratory rate greater than 80, that is bad, and that is recorded as a 2. Basically, we're trying to get a scoring system where we can objectively say without a doubt that this neonate needs mechanical ventilation. In assessing cyanosis, when there is none in room air, then that is 0, that is good. When there is none on oxygen, we give a score of 1. And then if cyanosis persists, even after starting on intranatal oxygen, that is 2. Retractions and grunting, when it's absent, it's good. When it's present, it's bad. And in terms of air entry, good air entry, of course, is good. And then decreased or barely audible are bad. So after collating all of these parameters, whenever we have a value greater than 7, that is impending respiratory failure and a very potent indication to commence the child on mechanical ventilation.
Yeah. Actually, you see, various facilities may have this ventilator, although we know for costs being capital intensive, not all centers have. We do. But what happens is, many times the decision to commence mechanical ventilation comes too late. And at that instance, we have a lot of issues. So that's why this scoring system is so simplified that anybody, a nurse can do it, a doctor can do it. So making that judgment is critical to success with mechanical ventilation. Now, we're talking about respiratory distress and respiratory failure. You see, so we're looking at various parameters to check. Now, we're discussing neonates now. But permit me to use the analogy of, let's say, a child comes with acute asthmatic attack. Now, if we look at separate respiratory distress and impending respiratory failure, actually respiratory failure, to be easy for us to remember. So if we look at the airway in this child, so airway could be obstructed maybe by secretions or by foreign bodies. So if airway is open without support, but the respiratory status, it's not all right, you think more of respiratory distress. Yeah. But there is a problem with respiration and the modified down scoring system is greater than 7 and the airway is obstructed, we think more of respiratory failure. Now, if you look at respiratory rate, yes, tachypnea, when respiratory rate is very fast, high, you are thinking of respiratory distress. But by the time you start having bradypnea, by the time bradypnea sets in, we are already getting towards respiratory failure. Remember, it's normal respiratory status, respiratory distress, and then respiratory failure. We do not want to get to the end of the spectrum. Now look at respiratory effort. The child who is normal has good respiratory effort. The child who has respiratory distress, increased respiratory effort. The child in respiratory failure, no respiratory effort. So not every quiet person is peaceful. So not every quiet person is peaceful. So long sounds on auscultation. So if we auscultate the airway of a child that has normal respiratory status, of course, our vesicular breath sounds for older children, and the bronchovesicular breath sounds for children below 3 months, you'll find it. But if there is auscultation, respiratory distress here, they are clear. Yeah, but then abnormal sounds start coming up, thinking of respiratory failure. like respiratory rate, so heart rate goes also.
Yeah.
So if we have tachypnea, tachycardia, respiratory distress, tachypnea, bradypnea, bradycardia, we are tending towards respiratory failure. So by normal taking of vital signs that our nurses do, it should be easy to tell, come on, there's a problem here. So level of activity. The child who has normal respiratory status is calm. The one in respiratory distress is agitated. The one in respiratory failure is not responding. You see, so not making any respiratory efforts, responsiveness is poor, not there. Then looking at the capillary beds, pallor for respiratory distress, and the child is actually getting cyanotic in the child with respiratory failure. These are important pointers that should trigger immediate care and need for ventilation. Well, we have this table just to give us normal values of arterial blood gases, because we said in our indication for ventilation, we talked about helping the effort, respiratory distress, respiratory failure, which we've discussed. The next one was abnormal arterial blood gases, and that's why there is a slide for normal blood gases as displayed. Yeah, so can you tell us about?
So concerning the blood gas, it's a very important investigation to do for every child that is being ventilated. Reason is because we don't want to tilt a child into acidosis or vice versa. For the preterm neonates, things that we need to look out for is to ensure that the pH is between 7.25 and 7.35, which is a bit more increased in a term neonate, where we have the normal as being between 7.35 and 7.45. These are values that we need to just look at, maybe create a chart in our specific ICU locations, have them, and then just take a good look at them so that pari passu, as we are managing every child, we can know exactly what is expected.
Yeah, so from this slide, we already know that there could be need to ventilate a preterm unit. So we have these values for preterm units. There could be reasons for ventilating a term unit, and so we have values. Now, persistent pulmonary hypertension of the newborn is a special category. That's why we have it there. Now, we know for persistent pulmonary hypertension of newborn that in utero, because gas exchange is via the placenta and the lungs are collapsed, we know that the pressure in the right chambers of the heart is way higher than the left, unlike postnatal life where we have the left dominance. So in utero is right dominance. When the baby is delivered, with separation of the placenta and the first breath the child makes, the child cries, the pressure drops. So, but if for any reason there is persistence of that high pressure on the right chamber, that's the old term used to be called persistent fetal circulation. Currently called persistent pulmonary hypertension of the newborn. So these parameters are there. We would look at these children who commonly have very fast respiratory rate. We've had babies with persistent pulmonary hypertension in the newborn in our neonatal intensive care unit with respiratory rate of 120. Just imagine 120 when maximum respiratory rate should be 60. So we're having babies with twice the upper limit of respiratory. So it's quite important we bear this in mind. These children can easily tilt to respiratory failure. They are candidates for mechanical ventilation. So still on acid-base balance, this is just schematic. We just want everybody, want our participants to relax. So we make this explanation here. So this diagram is just like, remember, elementary physics, where we have the fulcrum at the middle, and then we have two weights, left and right. I think this is so elementary for us to know. So on the left side of it is carbon dioxide that is excreted via the lungs from the tissue, vented out via the lungs. And then we have bicarbonate, which is also produced and excreted via the kidney. Now it helps to buffer. Good. So if we have a balance in the equilibrium, the pH is at its best, what it should be based on the normal values for the various gestational age that we discussed present. So for preterm, 2.25 to 7.25 to 7.35. Yes. So it's there. Now, if for any reason the pH drops, that's if we have more of carbon dioxide or less of the bicarbonate, the weight tilts, or more of the bicarbonate, the weight tilts towards the left, my left here, and you have low pH and more of carbon dioxide. So the partial pressure of carbon dioxide increases. So, but this is the balance. We will look, I think I'm already explaining the next slide. Good, I was explaining the next slide. Yeah. So fine.
All right. So, acid-base issues have always been really problematic since even medical school days. But there's a simple way to it. When we recognize that the acid, the CO2 is acidic, so increased acid, increased CO2 will tilt the pH to an acidic pH. So we would have acidosis in that case. And then when we know also that bicarbonate, that's the HCO3 that has to do with the renal system, is alkaline, increased bicarbonate in that sense will tilt to alkalosis. All right, so that's just the baseline towards it. And that's what this schematic is showing us here, that when there's increased CO2, which is caused by carbon dioxide buildup, reduced respiratory drive in the neonates, reduced ventilation, those things will lead to respiratory acidosis, and that is a potent indication for mechanical ventilation.
Okay, so now.
So when we are ventilating, Dr. Peter, what exactly do we hope to achieve in that situation?
All right, very good. So having discussed the basics of so far, we say we want to provide adequate oxygenation. Remember, one of the reasons we said low, that's hypoxia, low levels of oxygen. Now, we want to oxygenate, we want to ventilate. There's a difference between oxygenation and ventilation. We want to ventilate, that we want to get out carbon dioxide. We want to oxygenate, that we want to get in oxygen. Now, when this is done, there is optimal systemic oxygenation. And remember the definition of a mechanical ventilator in the first place. It's an automated device that we use in people who have increased work of breathing, which is as a result of a respiratory, pulmonary, or neurologic dysfunction. So we want to decrease the work of breathing. That's just the point here. We want to decrease the work of breathing. We want to maintain the desired arterial blood gas. Remember, we said respiratory acidosis, hypoxia. There are reasons why we need to ventilate. And we want to minimize lung injury. Just imagine the barrow trauma of ambu-bagging, the way we used to do in the peripheral hospital then in training. So you keep ambu-bagging. So the mechanical ventilator is a smart device that can pick all the inputs we make to give us what exactly. So these are the things we hope to achieve. Good. So, but before we ventilate, yes, we have to intubate these babies. So because the babies, we have the baby, we have the device, the mechanical ventilator, and we have the link between the baby and the mechanical ventilators. So based on weight, based on gestational age, we can tell the size of the endotracheal tubes, can tell the size of the laryngoscope, and we can tell the depth of insertion. So Dr. Mogaji, you tell us, assuming you have a baby who is 1.5 kg, what would be the size of laryngoscope blade you want to use?
All right, so baby who is 1.5 kg would fall in the category between 1,000 to 2,000 grams. And so it's important to note that the ET tube size for such a child will be a size 3. Laryngoscope size will be a 0.
Yes.
And the laryngoscopes are from 000 to 1,
Yeah.
where 000 is the smallest and 1 is the biggest. So we maintain that at 0, and then depth of insertion for such a child will be 7 to 8 centimeters. And it's also important to note that in recent times, medicine is tilting towards non-invasive mechanical ventilation. And maybe Mr. Buhari, a panelist, will be able to tell more.
Yeah, so we have a panelist who is loaded and set to talk to us from the GE company, the medical rep. He will tell us more about that. But I would like our listeners to please note this formula of the depth of the insertion of the endotracheal tube. So it's 6 plus the weight in kilograms.
Yeah.
That's simple. So the question is, if I have a child that is 1.2 kilograms, will I say 6 plus 1.2? That is what?
7.2.
7.2. No, we just say 7. We round up to the nearest whole number. But it's important we bear this formula in mind. Okay, fine. So we've been talking about the deep things of how to identify hypoxia, but you don't see low partial pressure of oxygen in children. You don't see elevated levels of bicarbonate in children. What are those clinical conditions for which our listeners can easily, as soon as you identify, this child requires mechanical ventilation? Or if it's not there, the center where you can make your reference to that can get it. So like we said from my introductory slides, we even have the transport incubator that can receive babies. You get the point. So we would want to maintain babies in thermoneutral environment. But what will I see in a hospital somewhere that will say, no, this child requires mechanical ventilation?
Thank you, Dr. Peter. It's in this slide, we'll try to make it actually plain so that we'll see how those indications marry with the conditions that we're going to see. So for a child who fails to initiate spontaneous respiration, this means that this child is not inhaling and exhaling by themselves.
Yeah.
So because the child is not inhaling, child is most likely going to be hypoxic.
Yes.
And then because the child is not exhaling by themselves, also, child is going to be building up carbon dioxide.
Yeah.
So that indication of hypoxia and increased partial pressure of carbon dioxide is going to be present in such a child. Respiratory distress.
So just to add, you see, that's why we say failure to establish spontaneous release despite bag and mask ventilation. So every time you have to ambubag a child, by the time you are getting ambubagging more than 10, 15 minutes, and the child has not peaked, because if that child has just apnea, by tactile stimulation, the child should pick up spontaneously. Now you've ambubagged for up to 10 minutes. You are ambubagging, you stop ambubagging, the child is not picking up spontaneous. That child needs to be intubated and ventilated.
Yes, you're very correct, Dr. Peter. In cases of respiratory distress syndrome, where we have poor lung maturity, especially in preterms, and inability of surfactant not being produced yet, it also reduces the work of ventilation in such children. And apnea of prematurity, remember we spoke about severe apnea with bradycardia as an indication. So when we have apnea of prematurity, it's a condition where we might need to ventilate a child. In cases of persistent pulmonary hypertension of newborn, as has been discussed earlier, meconium aspiration syndrome, is also a situation where ventilation is disrupted, part of which meconium destroys surfactant. It blocks that exchange, and then causes an hypoxic and a child who is not ventilating well also. Septicemia And sometimes in pneumonia, it's very funny with newborns where very low temperature, high temperature, low um, respiratory rate, high respiratory rate, all can be indicative of neonatal sepsis. And we have to have a very, very sharp skill to identify and pick this up so that we can help such children that we diagnose early. Because as much as we talk about mechanical ventilation, early commencement of that ventilation is a very important aspect that will let us know, that will help us with the success or failure of the ventilation. Critical congenital heart diseases, because of the relationship with the heart and lungs. And then diaphragmatic hernia. In following slides, we're going to see how a diaphragmatic hernia can impact with disrupt ventilation and respiration.
Yeah. Of course, diaphragm is a muscle of respiration. It's there. Okay, fine. Now, welcome at this stage. I need to say welcome because the game has started.
All that is like introduction to the real deal.
But don't, when lecturers say welcome, then you become scared. But we have just a few slides, and we'll make it as simple as possible. So, we want to discuss the mechanical ventilation parameters. These are absolutely important because we know that we are giving oxygen and then we are controlling the ventilation. It's just like you are making prescriptions, you need to know the drug, the routes, the dose. You get the point. You need to know which antibiotic you have to give via infusion, the one you give push and all that. So you start. Let's know, what is FiO2?
So FiO2 in full is fraction of inspired oxygen. And as Dr. Peter said, oxygen is a drug actually, and we have to know what dose we are giving a child. As we all are in our respective locations, we are receiving a dose of oxygen, and that is 25% of oxygen and 21% of oxygen in room air. And we can decide to go between 21 to 100, but it is usually helpful that we start small and then increase as indicated. So we don't say start this child on 100% oxygen because of the complications that are associated with oxygen delivery, part of which is bronchopulmonary dysplasia and
retrodental fibroplasia.
Yes.
Retinopathy of prematurity.
Yes, that's a retinopathy of prematurity. And it will be very unfortunate that we're trying to help a child and then send them away with complications.
Yeah, so you have this target. You want to start low and increase. So you see the machine is delivering FiO2 of say 21, and the baby is receiving oxygen, and you know how much oxygen is getting in using your pulse oximeter. So at every FiO2, we want to check how well oxygenation is going on. So we are expecting a target oxygen saturation of 92 to 96.
Yeah.
So that's good. So we increase as it should be. Yeah, so fine. So talk about minute ventilation. Remember, ventilation has to do with gas exchange. Ventilation has to do. So we could have respiratory movements with poor ventilation. So ventilation in 1 minute has to do with the tidal volume plus the respiratory rate, because it's the volume of oxygen that resides that help the ventilation with the breathing movement that occur. So of course, if we have this formula rearranged, respiratory rate is minute volume minus tidal volume. We should increase minute ventilation when we are to treat children with persistent pulmonary hypertension of the newborn. Like I said, we've had babies with persistent pulmonary hypertension of the newborn with respiratory rate of as high as 128. Now, respiratory rate is not the problem there, is the ventilation. Good. So meconium aspiration syndrome, those with raised intracranial pressure, you are hyperventilating.
Yeah.
You get, for those ones to reduce intracranial pressure. Good. So what is tidal volume?
So tidal volume is the volume of air that we inspire and expire in a baseline mode. So that's in normal respiration.
Yeah.
And then luckily, it's also one of the settings that can be imputed in the ventilator mode. So you can determine what tidal volume for a child that you are ventilating, that's what tidal volume the machine should give. In preterms, it's expected to be between 4 to 6 mils per kg. And in term children, in term neonates, we expect it to be between 7 to 10 mils per kg. And for those of us that have had the benefit of interfacing with a mechanical ventilator, some of these things are preset, especially in really up-to-date machines, so that by the time you impute the details of that patient, you put in the weight, you put in the height, calculate body surface area. By the time you're setting your modes, it will most likely give you a preset tidal volume within this range that is expected to be delivered to the child. So, Dr. Peter, please tell us about the peak inspiratory pressure.
Okay, fine. So before I do that, dear listeners, I want to set a quiz. Let me know if we are vibrating at the same frequency. So we have a baby who is 2 kilograms. We have a baby, so please put your answers in the chat box. We have a preterm neonate, low birth weight, who is 2 kilograms. Please calculate the range of tidal volume that you will set on the ventilator for this child. Are we together? All right, fine. So I'll be checking to know what our responses will be. Now, after discussing tidal volume, we say peak inspiratory pressure. Peak, oh, fine. So very good. We've had people already very, very fast and fast fingers. But your answers in the Q&A, please. Thank you. Peak inspiratory pressure. Peak inspiratory pressure. Now, when we inspire, the highest pressure limits applied to the air. So inspiration is an active process.
Yeah.
Whereas expiration is passive. So with the volume of air coming and giving its pressure to the airways, the highest pressure that is applied to the airways during inspiration is the peak inspiratory pressure. Good. So the flow rate of the air coming in of oxygen plus the volume tells us a lot about the peak inspiratory pressure. Now, the peak inspiratory pressure actually determines the tidal volume we get. So now, for mechanical ventilations, we set peak inspiratory pressure at a range of 18 to 20 centimeters of water. Now, let's go back to the Q&A and check for answers. Let's know tidal volume. Good. So we have, wow. So we have a lot of answers. So we are making progress.
We are becoming.
We are good teachers.
We are becoming neonatal ventilators.
Yeah. So we are making progress. Yeah. So we said, let me just give. So this child is 2 kilograms. So and for preterms is 4 to 6 mils per kg.
Yeah.
So it will be 8 to 12 mils of tidal volume for a baby who weighs what? 2 kilograms. So it's important we bear this in mind. I realize that one of the biggest challenges, you have the machine in front of you. You don't know which commands to give. You have a live baby in front of you. You need to correlate what you are seeing on that baby with what to key in. So we're happy we are making this progress. So yeah. Okay, more answers there. Good. Okay, fine. So we've dealt with fraction of inspired oxygen,
minute
ventilation, tidal volume, peak inspiratory pressure. So let's make progress. So now, people will say on the phone, I'll be called and say, okay, what PEEP? So what is PEEP? So PIP, peak inspiratory pressure. Now there is also PEEP, positive end expiratory pressure. It's important that we have this thing very clear. PIP is a pressure, the maximum pressure exerted on the airways during inspiration. What about during expiration? When we inspire, the alveoli gets filled up. It elastic, it dilates. When we expire, there is an elastic recoil, we push out carbon dioxide. Now, the peak end expiratory pressure is a pressure at the end of inspiration that keeps the alveoli back from collapsing. So you easily get this understanding from a balloon. So you blow, you inflate a balloon. By the time it's deflated, it loses, will I say, the globular shape.
Yeah.
We don't want our alveoli to collapse. So we still want something residual. So it's a pressure at the end of expiration that keeps the alveoli back from collapsing. So it is important that these values are clearly known and the settings on the mechanical ventilation well understood. So safe and effective peak end expiratory pressure is like 4 to 6 centimeters of mercury, centimeters of mercury, yeah. So, so low levels, we have them, medium levels, high levels. Now, you choose these values based on the clinical condition of the child. So if the child requires high oxygenation, maybe in acute respiratory distress syndrome, you use a higher value. Good. So that's as stated there. Now we talk about flow rate. Flow rate. The volume of gas used for mechanical ventilation per minute. So flow volume over time. So the flow rate determines the peak inspiratory pressure, because we said peak inspiratory pressure, the peak pressure exerted on the airways. So if we have flow of the gas very fast, volume very high, the peak PIP levels will increase. So, and waveforms, the mechanical ventilator interface, could have the interface for keying in these parameters and the interface for the waveforms, which from visual inspection you can tell. But we'll leave that now. There's what we call the inspiration to expiration ratio and the respiratory rate. These parameters will give the normal values for them as we progress. However, the flow rate. So please, thank you, Charles Mwigwe. Yeah. So it is centimeters of water. It's centimeters of water, not centimeters of mercury. Yeah. So PEEP is 4 to 8 centimeters of water. Yeah. So and okay. All right. So we make progress. So inspiration time. Yeah, we said inspiration is an active process. So something that is active relative to what is passive, right?
Yeah.
So we breathe in actively. And if we remember elementary introduction to clinical, Hutchinson's textbook of clinical examination, those diagrams, inspiration is active, is longer. Expiration, is active, is short, and expiration passive. So because inspiration is active and expiration is passive, inspiration is shorter, takes energy. Expiration is usually longer, 3 times inspiration. So we want to ask another question. I wouldn't talk about this. I hope you are looking at the slides. I hope we are together. So we have a baby who is a macrosomic baby who is 5 kg. What should be the inspiration time? A macrosomic baby who is 5 kg, what should be the inspiration time? Fine. While we wait for you to put your responses, we'll make progress and come back to see if we're able to get it. So inspiration expiration ratio, we said normal inspiration, if it's 1 minute, expiration should be 3 minutes. Just, it should be seconds, right?
Yeah.
So in respiratory distress syndrome, we have it as preset at 1 to 2. Good. So now let's see, we have some answers already. Okay. So more attempts. We have some people say 0.5 seconds. While that may not be absolutely wrong, we want exact figures. What was the weight of the child I said? Oh, yeah. Thanks. So that, yeah. So so do we have an explanation for this? There's a rule of the thumb that it's the weight in kg divided by 10. So if we have a baby who is 3 kg, inspiration time is 0.3 seconds. Now, let me ask the audience another difficult question. So for those who have been able to get it, I can see, thank you, Ngozi, Charles, Sebastian, and Uche, yes, from Kingdom of Saudi Arabia, we can see you. Now, we have this same child who is 5 kg. What is the expiration time? Can we task our audience more? We have a baby who is 5 kg. What should be the expiration time? Normal expiration time. Now we are trying to go from mathematics to further maths, but you really have this in front of us here. So we have an answer already. Wow. Yeah, so Uche Opara has said 1.5 seconds. So we have somebody else said 1 second. Let's see. So what should it be, Dr. Mogaji?
So for a normal inspiratory to expiratory ratio, we expect that it should be at a ratio of 1 to 3. So that means that if it takes one second to breathe in, it should take us 3 seconds to breathe out. So for a child who it takes 0.5 seconds to breathe in, then it should take that child 1.5 seconds to breathe out. So well done to those that got the answers correctly.
Yes, so a big shout out to our active neonatologists. So mean airway pressure is determined by a combination. So the pressure on the airway is determined by a combination of all these factors we've talked about. And so this is a tabular display of all we've been saying. So which one could have beside the mechanical ventilator just to guide. We have waiting our speaker from the GE company, but we'll just discuss this slide and then we'll hear some expert contributions. So it's important to know that the mechanical ventilator is ventilating, the baby is ventilating, and we are connecting two things together. It's just that the baby is not ventilating sufficiently. So it's important we understand the dynamics between the two of them. So the pulmonary dynamics and the ventilator dynamics. So the baby spontaneous breathing sequence, the ventilator mechanical breathing sequence. So we know easily from that of the baby that when we want to inspire, we get in air, the diaphragm moves down. When the diaphragm moves down, it creates space for air to get in during inspiration. As air is coming in, the intrathoracic volume increases. Yeah, so just get that. So the intrathoracic pressure decreases.
Apologies. Let's return to that slide. Okay.
Oh, fine. So as the diaphragm moves down, air rushes in and the intrathoracic volume increases. Between the lungs and the chest wall is the pleural space. So it increases, the intrapleural pressure decreases. There's a negative pressure that is created by the suctioning in of air. So that pressure creates a gas flow into the lungs. So pressure gets into the lungs that way. So diaphragm moves down. There is a creation of a negative intrapulmonary pressure. And then that sucks in like vacuum effect for gas to get in. Are we together? So, but the opposite, it's something different when it comes to the mechanical ventilator. The mechanical ventilator is set. The mechanical ventilator, yeah, we can see Abdullah Ibuari on the beside us now, fine. So the ventilator is set and then there is a push because it's doing it automated actively. There is a pressure difference. So the pressure difference creates a positive intrapleural pressure. That's from the machine to the lungs. So gas flows because of positive pressure difference from the machine to the lungs, which creates a change in volume. So whereas there is a suction effect of negative pressure when it is the pulmonary mechanics, there is a positive effect of push of gas flow when we talk about the mechanical ventilator. So fine. So we'll be discussing ventilator modes briefly, but at this point, we would want our dear presenter Buhari from GE to please unmute your mic and let us hear some expert contributions. Okay. So please, Mr. Buhari, your microphone is muted. If you can hear us. Oh yeah, fine.
Yeah, hello, Dr. Peter. Hello, everyone.
Yeah, thank you, sir.
Yeah, are you expecting me to present now?
Yes, yes.
Oh, okay.
So you have 15 minutes, sir.
Sorry?
15 minutes.
All right, then. So I'll just set up my slides to share.
Okay.
Seems like it's disabled from my end.
You can share your slide, please.
Okay. It's still telling me that the host disabled participant screen sharing.
Okay, so you are a panelist. You can share your slides.
It's still showing me an error message. So I'm not sure why. Let me try to reconnect. Maybe that would help resolve the issue.
Okay. Okay, hello, can you hear us?
Yes, I can hear you.
Okay, so I don't know, you are a panelist, you can share your slides.
Yeah, I assume so, but it's still giving me the error message that host disabled participant screen sharing. So it's not sharing my screen.
What? We make co-host. Yeah, make co-host. Yes. Yeah, so we can see you now.
Okay, it's the slide.
Okay. All right.
So we can see your screen now, Mr. Buhari.
Okay.
So waiting for your slides. Very good.
And your video is on.
Yeah. It's all right.
All right. Can you see my screen now?
Yes.
And my audio is fine?
Yes. Yeah, but audio is no.
Sorry?
We need more audio volume.
Okay. My audio is at the highest. Let me see if I can increase my voice.
Okay. All right. So go ahead with the presentation. We can hear you.
All right, thank you everyone. And thank you Limi Hospital for this opportunity to make this presentation from GE. And it's been a very good working relationship with Limi hospitals, including the Limi Children's Hospital. And as part of our efforts at GE is for us to continue to support our partners to see how they continue to improve the services that they offer to their clients and the patients who are in extreme need, especially in those critical moments that really matter. And providing neonatal ventilation care is certainly one of those moments. And we're proud partners of Limi Hospital in being able to achieve this goal. I'll do a very short presentation from us on the GE neonatal ventilation with a focus on the Cascape RH60, which we currently do have at Limi Children's Hospital. Part of what the solution is trying to offer is to provide the best and the gold standard in clinical decision making for clinicians in providing support for neonatal ventilation with the Cascape RH60, where three key pillars for what we are trying to do is ensuring that when the baby gets on the ventilator, we provide all necessary means and possibilities for the clinician to mitigate any clinical risk that might arise and complications that might arise with the use of mechanical ventilation. As we all know, the major concern most times in putting babies on the ventilator is usually on the risk that would come and the complications that might come in providing that support. And what we're trying to do is to focus as much as possible in providing solutions, both clinically and also in terms of technology to be able to meet those needs. Also, for the complications and the challenges with managing neonatal patients with the lungs, especially in preterms, then being able to provide different means of providing support, whether non-invasive ventilation or providing very good means to be able to match the needs of the lungs and the alveoli of the neonates becomes very important. And so having different ventilation modes that can meet the needs both in invasive and non-invasive ventilation, and in each instance with the specific needs of the lungs, then becomes very, very important. And this is one key pillar that we focus on. And then we know that a significant amount of the time that ventilation support is being provided by the clinician is trying to get the baby off the ventilator. So providing advanced technologies and tools that can help the clinician to be able to decide when the baby is ready to be weaned off the ventilator then becomes important. And this is one of the 3 key pillars in designing how the Cascape RH60 function. So we have a device for you that is expected to give you the most brilliant and innovative user interface, expert clinical tools to be able to help you easily adopt the use of mechanical ventilation. And with the Cascape RH60, for those who have used this device in different facilities, both in Nigeria and outside, they would be able to acknowledge not just the sophistication and scalability, but also even the simplicity in being able to navigate and provide tools that clinicians are able to use to provide support. And with the Cascape RH60, we're able to provide trends that the clinician will be able to see the progress of the patients that he's managing, being able to have different views that the clinician is able to see different parameters that are currently being monitored on the patients, and also the clinical tools that enable the clinician to protect the lungs of the patient, determine how the patient is being weaned, and in being able to provide more advanced tools that help the clinician to be able to provide the most optimal of care to their patients. And especially for the neonates, then we have special neonatal option that is increasingly being designed and developed to help provide the best care for the tiniest of patients who would provide the most tricky of challenge in providing ventilation support. And with the Cascape RH60, currently with the FDA, we have an approval and a validation to be able to provide support for patients as low as 0.25 kg. And so some of the most tiniest of patients that you might have, then we have solutions to be able to help you provide that support for those patients. And in the ventilation, part of what the Cascape RH60 offers is very highly sophisticated and designed volume support ventilation, which provides breath by breath adjustments to the inspiratory pressure that is required in the patient, while delivering the most optimal of volume to help in recruiting the lungs and providing both immediate and also adjunct support to the patient in maybe surfactant administration and other supports that might be needed. The nasal CPAP enables you to be able to provide spontaneous ventilation at PEEP or peak inspiratory pressure level at a rate that is set to deliver specific breath by breath supports. And so providing ventilatory support with non-invasive ventilation is one key target that we are trying to deliver. And recently, with the introduction of the high flow oxygen therapy support, this is a continuing development of this technology to ensure that with the different needs that the patients, especially the preterm and neonatal patients would have, we would be able to provide support for the most vulnerable of patients while providing the best in terms of protection of the lungs and being vigilant in providing that support. The Cascape RH60 is one which clinicians have attested to the ease of use, and especially in this age of devices where iPhones and even the most advanced of the Android devices are designed to provide easy menus to navigate, control, and provide the best way for clinicians to be able to, with a single touch, being able to swipe without too much menus, clinicians are able to navigate a ventilator to make it easy to adopt. And the focus of the clinician continues to be on the patient and less on an equipment or a technology that is cumbersome to be able to navigate. So in the design, what we have tried to do is you are able to see what we call the present. And in the present, you can be able to see, depending on what the clinician is more comfortable and preferred to have, whether in terms of numericals or waveforms or graphs and loops, the clinician is able to have different ways to be able to present the condition of the patient and be able to monitor how the patient is being supported and how the patient is responding to ventilatory support. And with menus which provide things like a cursor and a way to scroll around different times, especially when the clinician is trying to review data of the patient, the clinician is able to—
All right, excuse me, please, you have 2 more minutes to round up.
All right, sure.
Thank you.
Okay, the clinician is able to focus on what he's looking for to review the patient. We have very advanced alarm setup systems to ensure and to reduce the risk of alarm fatigue, which is a global phenomenon and concern. And then in lung protection, we have a wide range of ventilation modes that are able to provide clinical support for the clinician for different demands and different parameters for the patients. Like I said, weaning is a major concern. And so having an advanced tool which enables you to be able to provide weaning becomes important. And with different ways and types of ways clinicians are able to test spontaneous breathing, whether with TPs or CPAP or other systems with pressure support, we have a tool which enables you to be able to set a time or a duration for the patient to be tested, set parameters that would serve as top criteria in case if the patient fails or exceeds or goes under those parameters, then the ventilator switches back to the previous ventilation mode to be able to continue to support the patient, while you can come back and then review how the patient has performed to determine if the patient is ready for weaning. And there are different parameters that can help you to be able to determine how well the patient has done and how ready the patient is for weaning. You have tools that enable you be able to phase and time and effectively suction a patient, helping you guide through the different phases, pre-oxygenation, during the suction, and during the re-oxygenation phases. And then also tools that enable you to integrate nebulization, whether using an aerogen electrical vibrating mesh technology system or using a pneumatic system with an external oxygen source connected to the patient. And there are other maneuvers or procedures that you might want to incorporate into providing
right.
support for the
Yeah,
patient
please.
and in recruiting the lungs. And you
Time
have
up.
all these tools, both in terms of recruiting lungs for volume and pressure support to be able to deliver this. So thank you very much for the time and for the opportunity to make this presentation. And hopefully this has stimulated our minds into some of the things that we can look forward to in the technologies and the solutions we use to provide support. I've shown my email and also phone number in case if there is anyone who would want to contact to get some more insights and some materials into these. We have a lot of videos and tools that I can also share with you to be able to help. Thank you very much.
Thanks a lot. So we really appreciate the presentation from GE. You please hang on. So when questions come, we will handle together. Thank you.
All right, Chef.
Yeah.
Thank you.
So would share okay. So, yeah. Yes.
Okay, so we're going to move on to the ventilator modes. Our slides are about 2 or 3 to round up. So thank you, participants, for staying with us. It's very much appreciated.
So I want to share the PowerPoint. Just I need. Okay, fine. So we start with basic definitions. I don't know. Can you see our screen? All right, fine. So so basic ventilator modes we will discuss as we go along. So ventilator modes refer to the specific patterns of inflations. Yeah, so we want to ventilate the baby. We want to give oxygen to the baby, gas flow. So how is that done? That tells us about the mode. Now, is it spontaneous? That is, patient is the one initiating the inflation, or is it a mandatory mechanical one, which is initiated by the ventilator based on an initiating factor, which is usually time? So how does ventilation start? Yeah. Okay, so now the basic modes. How is each breath initiated? Is it a controlled breath, or is it a synchronized one with the patient's effort? So the initiation, if it's a controlled ventilation, breath is initiated by a timing mechanism unrelated to the neonate's own respiratory effort. So you are controlling, so you take control of the entire ventilation process. So the machine takes care of that regardless of the effort. Now, this could be common in severely asphyxiated babies who are literally making no efforts to ventilate. Or is it a synchronized mode, synchronized patient triggered? The breath is triggered by the neonate's inspiratory effort. So that tells us about the modes. We have some questions in the chat. Okay, fine. Right. So how is gas flow controlled? So we in the modes, how is it initiated? How is it sustained? How is it terminated? So that tells us about the modes, right? So we say initiation could be purely given to the machine, or the breath is triggered by the neonate and supported by the machine. There's as a synchrony. And how is gas flow sustained? Is it controlled by pressure? You remember the pulmonary mechanics of the baby, which we said the diaphragm goes down and there's a negative thoracic pressure that sucks in air. So there's a negative pressure difference. Good. So, or is it by the machine where we say there's a positive pressure difference and a gas flow? So it matters. So is it pressure controlled? A predetermined pressure is delivered, or volume controlled? A predetermined tidal volume is delivered. And how does it end? Is it time cycled? If you reach a specific time, remember our setting of inspiration time and expiration time. Is the breath terminated based on a predetermined time that has elapsed, or terminated by cessation, terminated based on cessation of inspiratory flow? So all these matter as to the modes, as we will discuss going forward. Okay, now, so we have the modes. Is it volume controlled or pressure variables? Now, for the purpose of this presentation, having done several trainings on ventilation, and we know how complex it could be at first instance, we have tried to simplify the presentation as we have done so far. And we just have 3 modes to discuss today. And they are all on the slides, as you can see. So the assist control mode, which is AC, then the SIMV, which is synchronized intermittent mandatory ventilation mode, or the intermittent mandatory ventilation mode. So we could start from any sequence at all. So you can talk about any.
So just to put things in context, in mechanical ventilation, as we've previously explained, either the machine is doing the whole work, or the machine is respecting the efforts of the neonates, or it is seeing the work of the neonate. That's allowing the neonate to take its own independent ventilation, and then when the neonate cannot take that breath, the machine takes it. So in that sequence, I'm going to say intermittent mandatory ventilation is the mode for the mechanical ventilator where the machine does the whole work. So for that, it is independent of patient's efforts. And even though the child has the chance to breathe, it does not determine the amount of ventilation that the machine is going to deliver. So just to simplify things, for the intermittent mandatory ventilation, whatever has been set that the machine should deliver, whether the child is making efforts or not, those are the things that will be delivered. And the disadvantages of that is patient-machine desynchrony. In terms of, for a child who is making some efforts, the machine will superimpose its own will on that child. In terms of the assist control.
Okay, so now still on the intermittent mandatory, so we have to bring it live, make it really real now in terms of clinical setting. So if we have a baby who has who is sedated, so we commonly don't find cases of neonatal tetanus as it used to be, but the child that you actually sedate, you understand, you knock off respiration entirely, or a baby with Guillain-Barré syndrome where effort, that's contraction, is actually a problem, or a baby with severe, maybe the stage 3 SANAT and SANAT classification of hypoxic ischemic encephalopathy, severe beta asphyxia, where effort is literally not there, the machine takes over completely. So I'm talking about the intermittent mandatory ventilation. This disadvantage of patient-machine desynchrony comes in here by the time the patient starts recovering.
Yeah.
So the patient starts making some effort, there is a desynchrony because the machine does not respect the effort of the baby. So it's just for us to know that there is that mode which is necessary for initiation, but we must bear in mind as the patient makes improvement. So what of SIMV?
So in situations where we have to use the synchronized intermittent mandatory ventilation, Here, the patient's effort is recognized. So when a patient can initiate and complete a cycle, the machine stays quiet. However, if there is no effort, then the machine delivers an intermittent mandatory ventilation. That's where we talk about its synchrony between patient and machine. Spontaneous breaths are given a chance here, and then there is diminished chances of desynchrony.
Yeah, so because there's like there's a synchrony here. So we agree to work together. So it's a collaboration mode. So it's a collaboration mode here. So maybe we say IMV is autocratic and SIMV is democratic. So they share. So what of assist control mode?
Right. So in cases of assist control, the patient generates the trigger and the machine delivers the ventilation. How is this different from SIMV? In SIMV, the patient can go through the ventilatory phase of inspiration and expiration by themselves. When they cannot, machine delivers. But in assist control, patient generates the trigger. So machine does not actually wait for the patient to complete the cycle. Once that trigger is activated, the machine notices it as the cry for help, so to speak, and then delivers a mandatory ventilation. Here the respiratory.
Okay, please. And let's set a quiz for the audience again. Let's be sure we are following. I ask a question. I purposely ask this question away from the answer to see if we are following. So if we have a 2 kg neonate, I always like 2 kg, a 2 kg neonate who has apnea. Now, this child is apneic regardless of caffeine citrate. Which mode will you choose? Because that's the challenge with using the mechanical ventilator. Your theory must match with the mode you are choosing. So we have a child with apnea, breathes, stops breathing, breathes. Which mode will you choose? Please, I will be happy to get your answers in the chat box. Let's know if we are making progress. So more on assist control.
Right. So in cases of assist, when we have to choose the assist control mode, the respiratory rate is based on patient's inherent rate. And this makes sense because what the machine is delivering is based on the patient's effort, right? So when the patient triggers, machine gives. So it's the patient in that way that is determining the respiratory rate. In this case, there is less work of breathing when it's compared with IMV or SIMV. Also, just to make things make sense, it's obvious that if patient is only starting the phase and the machine completes it, so in a child who we are seeing feeble respiratory efforts, but is still having poor ventilation, vis-a-vis hypoxia and poor oxygen saturation, we can place this child on assist control where you can generate the respiration, but allow the machine to take the work of breathing off of you.
Okay, fine. So we have a lot of answers already. Good. So we have so the answers are desynchronous. So the answers are desynchronous. So we have SIMV, we have IMV, SIMV, SIMV, IMV. Fine. So the answer from the chat box shows us there's a desynchrony of answers here. But let's see. Let's repeat what we said. So let me just try to say it in another way. We have a child who cannot, almost not making any efforts. We have another child who makes effort occasionally. Occasionally he cannot. Then we have the one that can make effort and complete. It's just that at intervals he cannot breathe. So we say intermittent mandatory ventilation for that type that you are taking full control over. Then the SIMB synchronized intermittent mandatory ventilation, the child can make effort and complete it, but there are times that there will be no effort. But if the child is going to make an effort, it's going to complete the cycle. Then we have the one where efforts are there quite well, different from where there is no effort at all. But that effort is not enough to complete, right? That's like what you said.
Exactly
So this tries to summarize everything. So in apnea, in having said this, people have started getting the correct answers. So you see, I'm a very good examiner. People are getting the correct answers now. So SIMV for a child with apnea, the period where the child will breathe and breathe completely. For the periods when the child will not breathe at all, then the machine needs to come into place.
Yeah.
So that's for SIMV. Whereas for assist control, patients' respiratory efforts are there. It's only a trigger that will use the machine to now assist and complete it. So having said this, if we are faced with a ventilator and we can intubate, which we've talked about the size of the ET tubes and the size and depth of insertion and the selection of laryngoscope blade, that is done. And then we have the ventilator put on. And we've talked about the parameters based on the weight of the child. Now we have the mode to choose. So that's the essence of the presentation that will not be blank in that regard. So we've discussed this mode this way. So what could be some complications that we'll watch out for when we have a child on mechanical ventilation? Okay, so we have Lillian Ekwem asking the question, will an apneic baby benefit from SIMV instead of IMV? Please clarify. Okay, so by apnea, the child is breathing, but has intervals where there is cessation of breathing that lasts more than 15, 20 seconds, associated with bradycardia desaturation. So there are intervals of normal breathing anyway. So we would prefer SIMV mode at that stage, because when the child can breathe, this child may be breathing for the next 10 to 15 minutes. The child could be breathing normally. But just after 15 minutes, the breathing ceases. And it ceases long enough for us to have bradycardia desaturation. That is apnea. In that instance, the SIMV mode comes into play to deliver the breath. So it's SIMV, not IMV. IMV, when the effort is, okay, so you have a child post-surgery, and maybe during surgery actually, and then post-surgery, where the effect of the anesthesia is still there, and the child is paralyzed completely, you take up the breathing and all. What about baby who has good heart rate but cannot take? So a baby who has good heart rate, that is periodic breathing. So if the heart rate is good, by the definition of, so I'm answering the question that was put. The question is, what if the child has a good heart rate? By definition of apnea, there is cessation of breathing long enough to cause desaturation in the face of with associated bradycardia. So if heart rate is normal, then that cessation is temporal. It's periodic breathing, is not apnea. Periodic breathing is not an indication for mechanical ventilation. Okay, so let's see if we've not missed. Okay, so that's just it. Right. Okay, fine. So what are complications to look out for?
Right, so one of the major things that we have to avoid in any situation is leaving a child worse off than we find them. And as much as
do no harm.
Yes, first do no harm.
Yeah.
And as much as mechanical ventilation is super important and helpful in terms of treating neonatal respiratory issues, it also has complications that are linked with it. We can have inadequate ventilation or oxygenation. In our bid to assess the child and determine the best possible mode, the best possible outcome, there's still that chance of failure of ventilation or oxygenation.
So this is why this presentation is important in terms of the mode that should be chosen for the patient you are seeing and the parameters you should use. So imagine we said inspiration time, we have a blanket rule of weight in kg divided by 10. So if we have a baby, a 2 kg baby again, we have a 2 kg baby, and we say the inspiration time ordinarily should therefore be 0.2 seconds. But if it is set shorter or longer than that, then we have a problem with the duration of inspiration. If we have problems with setting the various settings, you could have this kind of problem with ventilation. It's actually a major thing.
And usually there always needs to manipulate variables based on real scenarios. So take, for instance, ventilating a child, we take the arterial blood gas, we notice that we are tilting the child from respiratory acidosis, that's because of buildup of CO2, to respiratory alkalosis. There needs to be changes that we'll make to the settings to compensate for that. And that is why this knowledge is very, very important.
Okay, so sorry, we still have the same question from Lillian, Dr. Lillian. I was actually referring to a baby who suffered severe perinatal asphyxia that you are resuscitating, but cannot take over respiration
in spite
of good heart rate. So this is asphyxia.
Yes.
So, so what do you think?
So in a child who has good cardiac function with a shut down respiratory function, and from training, those are the children that will take 2-hourly shifts
to
bag and mask, you know. You can put the child on a mechanical ventilator, and intermittent mandatory ventilation is what you should choose for such a child. Yes. Because that child is not making any efforts, so you allow the machine to take over respiration for that child, and then you continue to check, as Mr. Buhari mentioned earlier, trial that the child is ready to be weaned off, machine will go on from there.
All right.
Right. So other complications that we can have is lung overinflation. That can happen as a result of putting in too high peak inspiratory pressure values.
Yes.
So on the ventilator interface, there's a point where you put in your values for the peak inspiratory pressure. Imagine overinflation of a balloon. I mean, there's no simpler way to explain that.
Yeah. So remember, peak inspiratory pressure is the maximum pressure exerted on the airways at inspiration. Back to our 2 kg baby. Back to our 2 kg low birth weight baby. That's why we asked that question initially. What is the normal peak inspiration? Do you remember? So it's important because if we overinflate, it will have it. So it's okay.
All right. So other complications is the air leak syndrome, acute lung injury from barrel trauma or volume trauma. And these are all from mismatch between what we are giving and what the baby is supposed to have. Atelectasis is also a complication of mechanical ventilation. Take, for instance, in children with respiratory distress syndrome. And it's important to note that ventilation is not a cure.
Oh, very good.
It is just to buy us time to deal with the baseline issues that is plaguing a child. So in a child with respiratory distress syndrome, where surfactant is the issue, if we place the child on mechanical ventilation, we still need to administer surfactants to manage that respiratory distress syndrome. We could also have hemodynamic instability, ventilator-associated pneumonia from not practicing aseptic procedures, especially when taking care of these neonates. Endotracheal tube obstruction could be from secretions, could be from kinking, and things like that. And inadequately managed pain and agitation due to the presence of ET tube or hypoxemia. That is why in similarly well children that, or in children that are active and are being taken in for surgery, we need to paralyze the muscles of respiration to make sure that there is no fight, so to speak, because ET tube is a foreign body.
Yes. So thanks. We really appreciate our participants for hanging on. We've tried to make a very simplified version on mechanical ventilation from our center here, the Limi Children's Hospital. We hope that this was a very exciting moment, an enlightening moment for us all. We are open to questions. So we have this question: a case of a baby with severe bed asphyxia, hypoxic ischemic encephalopathy stage 3, blood gases give features of mixed acidosis. Remember, we said our indication is respiratory acidosis, but in this case, we have a mixed picture, and then with carbon dioxide retention. Are there indications where SIMV is better than any other mode of ventilation? This child has severe bed asphyxia. You see, the primary diagnosis here is hypoxic ischemic encephalopathy, SANAT stage 3. The child is not ventilating at all. Okay, blindly, ordinarily, by rule of thumb, we will use IMV mode for this child. When there are acid-base issues, it should be corrected in its own terms. But what we are looking at as the diagnosis in this child is the hypoxic ischemic encephalopathy. In SIMV, the child, except this is not stage 3, maybe stage 2, where the child can make some spontaneous breathing movements, and the movement generates adequate ventilation, but has intervals where, so rather I would say it is either IMV or assist control in this picture that is painted, not SIMV.
Yes, it's also important to know that synchronized intermittent mandatory ventilation is a winning mode. So this is a child who is not making any effort is not one that you place on SIMV. A child who has improved, who you are actually thinking of stopping mechanical ventilation for, is a good place to do SIMV. I hope that has been able to answer your question, Dr. Uche.
Okay, so somebody asked, kindly explain Ehrlich syndrome. So Ehrlich syndrome, you have pneumothorax when there is a leak. Okay, when there is a leak of air from the alveoli.
Basically.
So when there is a leak of air from the alveoli, from alveolar rupture, maybe if the peak inspiratory pressure was so high and there is a rupture of alveoli, it leaks. We do not want to damage the airways of the child because we want to help. We need to help with ventilation, but we need to do it right. And hopefully the presentation would have given some light into this. So this is Limi Children's Hospital. Like the presenter from GE has clearly said, there is a good partnership between us and the GE, and our mechanical ventilator is a smart mechanical ventilator that can take from the tiniest babies, so babies below 10 kg. So whereas it is stationed in a neonatal intensive care unit, we can have infants that are more than neonatal age, the machine can still handle that. So in the event there is a need to get help, we are ready to help, assist in one way or the other. If there is need for taking managed care of the child, for preterms, we will be happy to link up with you using our mechanical, our transport incubator, because these babies, you see, like my co-presenter said, mechanical ventilation is not antibiotic. So a child who has malaria, you give anti-malaria. Mechanical ventilator is to support the child while you handle the main issue wrong with the child. I give an example. So you have a child with critical pulmonary stenosis, critical aortic. Those are critical congenital heart diseases. Yes, we want to help this child ventilate, but we need to source prostaglandin E1 to open up the ducts of the patent ductus arteriosus before we arrange for definitive surgery. So you see, it's important to bear in mind the entire picture while we support the baby. So we're always willing to do that. Thank you all. All right, so we've seen a lot of comments in the chat box regarding slides being available and sent. So provided you registered, the email with which you registered, you will get your CME points and then the PowerPoint slides sent to you via the email. Thank you for your kind participatory listenership, and we hope to be, we hope to still be with you next month, where we'll have another exciting session. Again, from Limi Children's Hospital at number 39, Ademola Adetokunbo Crescent, Wuse 2, Abuja, where we are. Thank you. So we have a question, right? Okay. While we wait for any other questions, we want to really appreciate Mr. Buhari, our clinical expert from GE, who has agreed to partner with us, whose presentation has thrown more light to our discussion today. Okay.
All right, so thank you, everyone. We hope to see you again next time. Thank you and have a good day.